This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hello friends, sometimes differentiating between equatorial posterior capsule tear and a zonular weakness can be a challenge. I had one such encounter in this case, and let's try to dive in deep and analyze it. So this is a 75-year-old gentleman, and as I keep telling, pseudoexfoliation is an extremely common condition and I encounter them on a daily basis, and it is so common in my practice. So the pupil is moderately dilating. We can see this pseudoexfoliation material on the pupillary margin, on the anterior lens capsule. The nucleus seems to be fairly dense, and at this stage there is no cross evidence of phacodonosis. So the zonular health I'll be able to assess only when I touch the anterior capsule later on. So I'll take a call on the IOL placement only after the intraoperative assessment of the zonules. The surgery is being done under a block, and 2 side port incisions are made. The capsule is stained with trypan blue. The chamber is filled with dispersive ovary. The globe is stabilized, and posterior limbal triplanar incision is created. Now I'm expecting some complexity in this case, so I want a good visualization. So I'm going to use a pupil expansion device. In this case, I'm going to use the Gupta pupil expansion device, and the device is loaded onto the cartridge. It is placed in the anterior chamber on the surface of the iris. And using 2 Sinskey hooks, each of these notches are then engaged onto the pupillary margin. So this is the time when I would actually come to know the health of zonules. The moment I touch the capsule to puncture with the forceps, I can see these radiating folds emanating from the point of contact, and this is surely suggestive of a loose bag with lax zonules. With a little bit of a pressure, I could puncture the capsule. The flap is raised, and as the capsule is being folded and being torn around, the highlighting feature is the folds which are just adjacent to the tearing edge. This is a classical sign of anterior zonular weakness. As the tear propagates, you can clearly see folds around the capsule. These are all suggesting zonular weakness. At this point, I need to make up my mind that what technique of IOL implantation I'm going to use. Now this case was scheduled for a single piece monofocal lens, but I'm now having second thoughts of whether should I continue with a single piece lens or go ahead and use the IOL trap technique with a 3-piece lens. A 5mm rhexis is done. Now is the time for hydrodissection. Now I believe in such eyes with generalized zonulopathy, good hydrodissection is the most important step. So this ensures that the corticocapsular adhesions are broken, and unless and until the nucleus is free from its attachments to the capsular bag, I wouldn't proceed for nucleus management. So as I'm trying to move the nucleus, initially I feel that the bag also is moving along with it, but subsequent repeat hydrodissections ensure that the nucleus is now relatively free from its attachments to the bag. The nucleus is rotating and the bag is held steady. So this is a sign which confirms that I can now proceed with nucleus management, and because the nucleus is relatively free, and the CTR insertion would be done later. Time to emulsify the nucleus. The superficial epinucleus and the cortex is aspirated. So as I'm getting ready to emulsify the nucleus, I will be reminding myself that I'd be as gentle as possible during the chopping and the lateral separation maneuvers. I begin by creating a small trench with couple of sculpting maneuvers. So about 30 to 40% depth I've reached. Now is the time to do the chopping. The tip is buried into the substance of the nucleus. I'm using just the longitudinal energy. Hold the nucleus. The vertical chopper goes down, and then there's a lateral separation maneuver. I'd like to draw your attention to the way I maneuver the nucleus. You can see I'm going to use the 2 instruments inside to do the rotation. It's bimanual rotation. I'm going to use both the chopper as well as the phaco tip to rotate. Now this maneuver is very helpful in rotating the nucleus without using excessive physical force. This technique is really helpful when we are dealing in such eyes with compromised zonules. So using two instruments to rotate the nucleus would be the best use of the physical forces without causing significant stress on the already compromised zonules. The same chopping maneuver is now being done in the second heminucleus. Since the nucleus is relatively dense, we don't expect it to crack in a first go itself. A little bit of patience is required. Multiple attempts of lateral separation ensure that the posterior plate eventually breaks out. So now we have multiple small fragments, and each of them now is being pulled up and emulsified. The plane of emulsification should be at the level of the rhexis margin, preferably. This would ensure clearer cornea on the post-op days. Now, before emulsifying the last fragment, I'm going to refill the chamber with OVD, and then the last fragment is emulsified. So now is the time to remove the cortex. So we need to remember that eyes having generalized zonular weakness, the cortex aspiration can be tricky. One of the reasons is we usually don't get a very efficient cortical cleaving hydrodissection simply because there is no counter traction by the zonules, as a result of which the cortex could be quite sticky to the capsular bag, and there is every risk of damaging the bag or the zonules during cortex aspiration. So I go in with my bimanual aspiration. I'm trying out the tangential way of stripping. This ensures a minimal chance of pulling out the zonules. As I'm removing this cortex, there's a momentary scare. I can see that the posterior capsule is coming along with the aspiration port, and it was scary. So let me replay and show you in slow motion how it looked like. The cortex is being pulled out. Along with it, you can see the wrinkled posterior capsule is coming out. At this stage, I wasn't sure whether it was an equatorial PC tear or was it just the loose bag trying to come along with the cannula. Now, how to differentiate? So this is a replay. Well, I convinced myself that this is not a PC tear and it is just the loose bag trying to come along with, and it is because of the lax zonules. The reason why I ruled out PC tear was I wasn't seeing any demarcation line, and secondly, if there was a PC tear with the irrigation being continuously on, I would expect it to enlarge a little bit, and there was none of this. So at this point I convinced myself that it is not a posterior capsule tear. The remaining cortex again is gently peeled out. And now is the time to implant the lens. Now before implanting, I would like to push the CTR into the bag because looking at the health of the zonules, I would definitely prefer to use the IOL trap technique rather than placing both the lens and the CTR in the bag. The CTR goes into the bag, and one trick to know that the CTR is gone in the bag is to look at this kink which is seen here on the rhexis margin. This is just for the beginner surgeon to understand that it is quite probable that the CTR can also go into the sulcus above the anterior capsule. So look at the margin of the anterior capsule. If you find this is kinking, well, this is a confirmatory sign that the CTR has gone in the bag. The trailing end of the CTR is now gently maneuvered into the capsular bag. Now is the time to place the lens. OVD is placed in front of the anterior capsule to create some space. An appropriately powered multi-piece lens is placed in the sulcus. First the leading haptic goes in, the trailing haptic is then dialed in. Time to remove the pupil expansion device. All the 4 notches are disengaged. The pupil expansion device is explanted out. Now is the time to remove the OVD both in front and behind the lens. Once the OVD is out, time to achieve the optic capture. With my irrigation in my left hand, the optic of the lens is gently tapped posteriorly so that the optic goes into the capsular bag while the haptics are in the sulcus. Ovalization of the rhexis confirms the optic capture, and this is what we are aiming for, and this would ensure a better long-term centration and stability of the lens. The side ports are hydrated. That's it, the case is done. These are the first day post-op pictures. There's minimal corneal edema, and these are the third day post-op pictures. The edema is decreased and the patient is doing well. So this was another case with a pseudoexfoliation, loose zonules, and a very tricky appearance of the posterior capsule which confused me, and I had to take a moment to analyze and differentiate an equatorial posterior capsule tear from an zonular weakness, because the way of management is totally different. If you're suspecting a posterior capsule tear, then a CTR is contraindicated, and on the contrary, if the diagnosis is zonular dehiscence, then CTR is the one which is going to be used. So there's a reason why getting to know these subtle signs is important for us to address this situation if it arises in the future. So that was it. Thank you for watching and hope you found this helpful.